All right, ready to dive in. Today we're tackling antihypertensive agents.
Oh, you mean those meds for high blood pressure?
Exactly.
Yeah.
And our main source, Dr. Khaled Hasan's clinical pharmacology lecture notes. By the end of this deep dive, you'll be able to impress your doctor with all your newfound knowledge,
And hopefully understand your own health a bit better, too.
especially if you're dealing with, you know, hypertension. I mean, think about it. How many people do you know with high blood pressure?
Tons, right. Super common.
It's like crazy common.
Yeah.
I read somewhere that almost 70% of people between 60 and 69 have it.
Yeah, you're right. And to add to that, the definition of hypertension has actually changed recently.
Really? What's different now?
So it used to be that 14E90 was the cutoff for hypertension.
Right.
But now, anything above 3080 is considered high.
Wow, that's lower than I thought. Why the change?
Well, it all boils down to risk. Even slightly elevated blood pressure can increase your chances of, all those serious health problems.
Like heart disease and stroke.
Exactly. So early detection is really key.
Makes sense. So how do we know where our blood pressure falls on, like, the spectrum? Is there a way to categorize it?
Yeah, think of it as a ladder
Okay, a ladder.
with different levels of blood pressure readings. So at the bottom, below 20/80, that's normal. You're good to go.
Perfect.
But then, once you're systolic, that top number hits between a 120 and 129, but the diastolic, the bottom number, stays below 80. That's the first step up. We call that elevated blood pressure.
So that's like a yellow light, a warning sign. Yeah.
Exactly. Then we move up to stage 1 hypertension, which is between 130, 139 systolic or 80, 89 diastolic.
Got it.
And at the top of this ladder, stage 2, the most severe is anything at or above 140 systolic or at or above 90 diastolic.
Okay, that puts things in perspective. And that's probably why they lowered the definition, right, to catch those early warning signs.
Exactly. Now, Dr. Hasan made a point of mentioning that hypertension is often called the silent killer.
That's a bit scary. Why is it called that?
Because you often don't feel anything, especially in the early stages. You could have high blood pressure and be totally unaware.
Going about your day feeling fine, but damage is happening silently.
Exactly. That's why those routine checkups are so important.
It's like a ticking time bomb you don't even know is there. So what causes blood pressure to go up in the first place?
Well, there are two main types, essential and secondary. Essential, also known as primary, is the most common, about 90% of cases.
So 9 times out of 10, that's what we're dealing with.
Yeah, and the tricky thing about essential hypertension is that we don't actually know the exact cause.
That's got to be frustrating.
It really is. It's like a puzzle with some pieces missing.
But we can identify certain risk factors, right?
Absolutely. Family history, age, race, lifestyle choices like diet and exercise, all those play a role.
It's funny, Dr. Hasan mentioned that higher education and income levels are actually linked to a lower prevalence of hypertension.
Oh, yeah, that's interesting. It could be a mix of things. Better access to healthcare, more knowledge about healthy living, maybe even less stress.
Or better ways to manage that stress.
Right, exactly. But let's talk about secondary hypertension for a minute, that other 10%.
So that's where they're a known cause.
Yep. It could be kidney problems, endocrine disorders, even things like sleep apnea.
Wait, really? Sleep apnea can cause high blood pressure.
Yep. It might seem weird, but conditions that disrupt your sleep can really mess with your blood pressure regulation. And there are other culprits too, like polycystic ovarian syndrome.
Wow, I never would have guessed those were connected. It really shows how everything in our bodies is linked, doesn't it?
It really does. And to make things even more complex, even some everyday medications can raise your blood pressure.
Like what? Give us some examples.
Well, think about those over-the-counter decongestants you take when you have a cold.
Oh, right.
Those can temporarily raise your blood pressure. Same with NSAIDs, those common pain relievers like ibuprofen. And even certain antidepressants can have that effect.
It's amazing what we put our bodies through. So how does our body even regulate blood pressure in the first place? I remember Dr. Hasan talking about those complex systems like baroreflexes and the renin-angiotensin-aldosterone system.
Those are the superstars of blood pressure control.
Okay, walk us through it. What happens first?
So let's start with the baroreflexes. They're like your body's rapid response team for blood pressure.
Rapid response team.
Yeah, these sensors are located in your aortic arch and carotid arteries. They constantly monitor the pressure in your blood vessels.
So they're like little pressure gauges.
Exactly. And if the pressure drops, they send a signal to your brain.
Like an SOS.
Exactly. And your brain immediately activates the sympathetic nervous system.
Which is our fight or flight response.
Yep, causing your heart to beat faster and your blood vessels to constrict, which quickly raises that blood pressure back up.
Wow, our bodies are pretty efficient. And what about that other system, the renin-angiotensin-aldosterone system?
That's where the kidneys come in to fine-tune things over the long term.
Okay, the kidneys are involved too.
Big time. So when your blood pressure drops, your kidneys release this enzyme called renin.
Renin, okay.
And that sets off a whole cascade of events, eventually leading to the production of angiotensin II.
Angiotensin II. Didn't we hear that name earlier?
You've got a good memory. Angiotensin II is a powerful vasoconstrictor. It tells your blood vessels to tighten up, raising blood pressure.
So it's like the opposite of those baroflexes.
Kind of, yeah. And to make things even more complex, angiotensin II also triggers the release of aldosterone.
And what does aldosterone do?
Aldosterone is the salt and water manager. It tells your kidneys to hold on to more sodium and water, which increases your blood volume.
Which then increases blood pressure even more.
Exactly. It's a two-pronged approach. Pretty clever, right?
It is. But what happens when this delicate balance goes wrong and we end up with chronic high blood pressure?
Well, that's when we need to step in with some interventions. And the first line of defense, lifestyle changes.
Right. You can't just pop a pill and call it a day.
Nope. Lifestyle modifications are crucial.
So what kind of changes are we talking about?
The usual suspects.
Yeah.
Losing weight if you need to, the DISH diet, cutting back on salt, regular physical activity, and moderating alcohol.
It sounds pretty straightforward, but how much of a difference can these changes really make?
Oh, a huge difference. Even losing a little bit of weight can drop your systolic blood pressure by about 1 mmHg.
Just 1 mmHg.
It might not seem like much, but every little bit counts. And if you switch to the DISH diet, you could see a reduction of up to 11 mmHg. And reducing your sodium intake can lower it by another 5 to 6 mmHg.
So all those small changes can really add up.
Exactly. But what happens when lifestyle changes aren't enough, or when someone needs more immediate help? That's where those antihypertensive medications come in.
Our topic for today. So let's break down those drug categories. Where should we start?
Let's begin with the classics, diuretics.
Diuretics, those are the ones that make you pee more, right?
Yeah.
How does that help lower blood pressure?
You got it. Diuretics work by getting your kidneys to flush out more sodium and water.
Okay.
And that reduces the volume of fluid in your blood vessels, which lowers the pressure.
So it's like letting some air out of a tire to decrease the pressure.
Perfect analogy. And just like there are different types of tires, there are different types of diuretics.
Of course, it can't be that simple.
Right. We have thiazide diuretics, loop diuretics, and potassium-sparing diuretics.
And each one works a little differently.
Exactly. They each target a specific part of the kidneys.
Okay, so let me see if I've got this. Dr. Hasan gave us a matching exercise in his notes. We have 4 types of diuretics: furosemide, amiloride, spironolactone, and hydrochlorothiazide. We need to match each one to its site of action in the kidneys.
All right, give it a shot.
Well, amiloride is a potassium-sparing diuretic, so it must be the one that works in the collecting duct, blocking sodium channels, so sodium isn't reabsorbed back into the bloodstream.
That's right. You're up to a great start.
Okay, next, spironolactone. This is a tricky one. It works by blocking the effects of aldosterone.
Remember aldosterone, the salt and water manager?
Right, so spironolactone messes with aldosterone's ability to hold on to sodium and get rid of potassium.
Exactly. You're getting this.
Okay, now hydrochlorothiazide. That's a thiazide diuretic, which means it acts on the distal convoluted tubule. It basically blocks a transporter there, so more sodium and water get excreted as urine.
You're on a roll.
And that leaves furosemide, which is a loop diuretic, right?
Yep.
So it must be the one that works on the ascending loop of Henle. It blocks the reabsorption of a bunch of electrolytes there, leading to, you guessed it, more pee.
You aced it.
All right. It's starting to feel like I know my diuretics. Anything else we should know about them before we move on?
Well, just remember that they can sometimes affect your electrolyte levels.
Like potassium, right?
Exactly. So regular blood work is important to make sure everything is balanced.
Okay, so monitoring is key.
Always. Ready for the next type of antihypertensive medication.
Get me with it. What's next?
Beta blockers. They're a pretty interesting bunch.
Beta blockers? I feel like I've heard that before, but I can't quite place it.
You've probably heard of them because they're used for a lot of different conditions, not just hypertension.
Okay, right.
But when it comes to high blood pressure, they work by basically reducing your heart's workload.
Reduce the workload?
Yeah, they lower the force of the heart's contractions.
So less force equals lower blood pressure.
Exactly. But how do they actually do that? Well, they block the effects of adrenaline.
Adrenaline, the fight-or-flight hormone?
That's the one. So by blocking adrenaline, they help your heart beat slower and with less force.
It's like they're telling your heart to chill out a bit.
Precisely. But they're not for everyone. Dr. Hasan pointed out that they're often reserved for specific situations, like after a heart attack or someone's at high risk for coronary artery disease.
So not always the first choice.
Right. And there are some situations where they should be avoided altogether.
Like what?
Well, if someone has asthma, for example, they could make breathing problems worse.
Makes sense.
And they're not ideal for people with severe peripheral vascular disease where blood flow to the limbs is already compromised.
Okay, so lots to consider. And I'm guessing there are also side effects.
Of course. Fatigue and a slower heart rate are common with beta blockers.
Not exactly the energizing effects of adrenaline.
Nope. Some people also experience exercise intolerance, meaning they get tired more easily during physical activity.
Yeah.
And there's also the potential for, well, sexual dysfunction.
Yikes, that's a big one.
It is, and that's why open communication with your doctor is so important.
Okay, good to know. Now, before we move on, are you ready for a pop quiz?
Hit me.
All right, first question. What adverse effect is linked to beta blocker therapy? Hypertension, hyperactivity, exercise tolerance, or sexual dysfunction?
Okay, this is a bit of a trick question, but remembering that beta blockers slow things down, the answer has to be sexual dysfunction.
Right. They're testing our knowledge here.
Oh, sure.
Okay, next question. How should beta blockers be stopped in people with ischemic heart disease and hypertension? Sudden cessation, gradual tapering over a few weeks, immediate switch to a different medication, or never stop taking them?
That's a crucial one. Stopping them abruptly, especially if you have heart disease, is a bad idea.
What could happen?
You could get a rebound effect where your blood pressure and heart rate suddenly spike.
Yikes.
Yeah, so the answer is gradual tapering over a few weeks.
Okay, so easing off the brakes slowly.
Exactly. Always talk to your doctor before making any changes to your medication.
Always good advice. All right, ready to tackle the next category of blood pressure medications.
Bring it on.
All right, let's talk about ACE inhibitors.
ACE inhibitors. They're fascinating because they really get into the nitty-gritty of the renin-angiotensin-aldosterone system.
Right, that chain reaction we talked about earlier.
That's the one. So ACE inhibitors block an enzyme called, well, ACE, which stands for angiotensin-converting enzyme.
Hold on, remind me what ACE does again?
ACE is responsible for converting angiotensin I into angiotensin II, that potent vasoconstrictor.
Right. It's all coming back now.
Good. So by blocking ACE, these drugs prevent angiotensin II from forming, which stops that blood pressure-raising process in its tracks.
It's like they're cutting the wires on the blood pressure alarm.
I like that. Now, when are ACE inhibitors usually the go-to choice? Well, they're often recommended as a first-line treatment for folks with coronary artery disease, diabetes, history of stroke, heart failure, or chronic kidney disease.
Wow, that's a lot of conditions.
It is, and what's cool is that they do more than just lower blood pressure. For example, in people with diabetes, they can help protect the kidneys.
So they're multitaskers.
They are. They're also a standard treatment after a heart attack, helping to improve heart function.
Amazing. But I have a feeling there's a catch. Don't ACE inhibitors have a pretty annoying side effect?
You're probably thinking of the infamous ACE inhibitor cough.
The cough, right. What causes that?
It's a buildup of a substance called bradykinin in the lungs. Normally, ACE breaks down bradykinin.
But when you block ACE...
bradykinin levels can rise, leading to irritation and that pesky cough.
So it's like an unintended consequence of messing with the body's balance.
Exactly. And to illustrate this, Dr. Hasan shared a case study in his lecture.
Oh, I love a good story.
Okay, so imagine this. Mr. Jones, 65 years old, has hypertension and type 2 diabetes. He's been taking lisinopril, an ACE inhibitor, for about a year, and his blood pressure is well controlled.
So far, so good.
Right. He also takes metformin for his diabetes, and his blood sugar is stable, but he has this nagging dry cough that just won't quit.
I see where this is going.
He goes to his doctor, who immediately suspects the lisinopril.
The ACE inhibitor cough strikes again.
Exactly. So this case highlights the importance of recognizing those potential side effects.
And connecting the dots.
Right. So what can be done for Mr. Jones? Well, one option is to simply stop the ACE inhibitor and switch to a different type of blood pressure medication.
Makes sense.
Or he could try an angiotensin II receptor blocker, or ARB for short.
ARB, okay. How are those different?
They have similar effects as ACE inhibitors, but they work in a slightly different way. Instead of blocking the enzyme that makes angiotensin II, they block the receptor that it binds to.
So they're bypassing the step where that cough-inducing bradykinin buildup happens.
Exactly. And there's another perk. ARBs have a lower risk of causing angioedema.
Angioedema, what's that?
It's a rare but serious allergic reaction that can cause swelling in the face, throat, and tongue.
That sounds scary.
It can be. So ARBs are a safer alternative for some people.
Okay, got it. What are some common ARBs?
Losartan, valsartan, candesartan are a few you might recognize.
All right, I'll try to remember those. Oh, and Dr. Hasan also mentioned aliskiren.
Aliskiren, yes. That's a direct renin inhibitor.
Which means?
It blocks renin directly, that enzyme that kickstarts the whole renin-angiotensin-aldosterone system.
Right, the first domino to fall.
Exactly. But there's a catch. You should never combine aliskiren with an ACE inhibitor or an ARB.
Why is that?
It can lead to some nasty side effects like kidney problems and dangerously low blood pressure.
So, too much of a good thing can be a bad thing.
In this case, definitely. As for side effects, aliskiren can cause diarrhea, and like ACE inhibitors, it can also cause cough and angioedema, although less frequently.
Okay, good to know. And it's off limits during pregnancy, right?
Right. Both ACE inhibitors and ARBs are a no-go during pregnancy.
Got it. So, lots to consider with these medications. Speaking of which, you ready for another matching question?
Bring it on.
All right, this time, we need to match these drugs to their class. Losartan, aliskiren, candesartan, lisinopril, captopril, and olmesartan.
Okay, and the classes are ACE inhibitor, ARB, or renin inhibitor.
Exactly.
Okay, let me see. Losartan, candesartan, and olmesartan are all ARBs.
Yep.
Lisinopril and captopril are our ACE inhibitors. And aliskiren, that's our renin inhibitor.
Nailed it. But with so many options, how do doctors decide which medication is best for each patient?
That's where their expertise really comes in. They have to consider all sorts of factors, like the patient's other health conditions, potential side effects, and even their lifestyle.
Like personalized medicine.
Exactly. And speaking of which, Dr. Hasan included a case study in his notes. A 59-year-old non-Hispanic white man comes in with hypertension, diabetes, and high cholesterol. His blood pressure is consistently around 50/93. What would be the best initial treatment for his hypertension? Enalapril, hydralazine, verapamil, or metoprolol.
Okay, lots to consider here. We've got to think about his diabetes and high cholesterol, too, not just his blood pressure.
Right. So what do you think?
Based on what we've learned, I'd say enalapril, an ACE inhibitor.
Ding, ding, ding. You got it.
Why enalapril?
Remember those protective benefits for the heart and kidneys that ACE inhibitors offer, especially for people with diabetes?
Right. It's like choosing the right tool for the job.
Exactly. It's not just about lowering blood pressure. It's about addressing the whole picture.
Makes sense. Ready to explore another class of medications?
You bet. Let's talk about calcium channel blockers.
Calcium channel blockers. I've definitely heard of those, but tell me more.
They're another popular option. They're particularly effective for certain groups, like Black patients and people with diabetes or stable ischemic heart disease.
Okay, interesting. Why those groups specifically?
Well, studies have shown that they're just really effective at lowering blood pressure in Black patients.
Okay.
And they don't have those potential negative effects on diabetes or heart disease that some other meds might have.
Good to know. So how do they actually work? What are they doing in the body?
Imagine tiny gates controlling the flow of calcium into your muscle cells, including those in your blood vessels. These gates are called calcium channels.
Tiny gates. Got it.
So, when calcium rushes into these cells, it makes them contract, which can lead to higher blood pressure.
Okay, so calcium's a bad guy here.
Kind of, yeah. And calcium channel blockers, as their name suggests, block those gates.
So they're like bouncers at the calcium club.
I love that. By preventing calcium from getting in, they help the muscles in your blood vessels relax and widen. We call that vasodilation.
Vasodilation. So more blood flow, less pressure.
Exactly. And just like with diuretics, there are different types of calcium channel blockers.
Oh boy, here we go again.
Right. We have non-dihydropyridines like verapamil and diltiazem, and dihydropyridines like nifedipine and amlodipine.
Okay, those are some tricky names.
I know. But the main difference is their effects on the heart.
Tell me more.
Non-dihydropyridines slow down your heart rate and decrease the force of contractions. They can also be used to treat irregular heartbeats.
So they're like a 2-for-1 deal.
Exactly. And dihydropyridines, they mainly act on the blood vessels, causing relaxation and widening.
So less impact on the heart.
Yep. They're often preferred for people who need to keep their heart rate stable.
Got it. So lots of options to choose from, depending on the individual's needs.
Absolutely. And one thing Dr. Hasan emphasized was avoiding high doses of short-acting calcium channel blockers.
Why is that?
They can cause your blood pressure to drop too quickly.
Which could be dangerous?
Exactly. It could trigger a reflex tachycardia, which is basically a super fast heartbeat.
Okay, so it's all about finding that balance.
Right. And what about side effects? Well, constipation is a common one, especially with verapamil.
Wait, I bet Dr. Hasan has a case study for this.
You know him too well. So picture this. A 45-year-old man is having trouble with constipation. He's on 2 blood pressure meds because his systolic was really high.
2 meds, okay.
He's taking lisinopril, chlorthalidone, verapamil, rosuvastatin, and aspirin.
That's a lot of medications.
It is. So what do you think is causing his constipation?
Well, based on what we just learned, I'm going to say verapamil.
You are correct. You're a natural at this.
This is kind of fun. But before we move on, can we go back to something? You mentioned that calcium channel blockers are recommended as a first-line treatment for Black patients. We didn't really talk about why.
Oh, yeah, that's a great point. It's all about personalized medicine.
Right.
So Black patients tend to have lower renin activity.
Renin, the enzyme that kicks off that whole chain reaction.
That's the one. So if renin activity is lower, medications that target that system, like ACE inhibitors and ARBs, might not work as well.
Ah, that makes sense. So calcium channel blockers, which work differently, might be a better option in those cases.
Exactly. It's all about tailoring treatment to the individual.
Love it. So, ready for one more multiple choice question?
Hit me with it.
Which of these is a recommended first-line treatment option for Black patients with hypertension? ACE inhibitors, beta blockers, calcium channel blockers, or alpha blockers?
Okay, that's easy after what we just discussed. The answer is calcium channel blockers.
You got it. Now, before we move on, can we talk about combination therapy?
Combination therapy, you mean using more than one medication?
Yeah, is that common for hypertension?
Very common, actually. Many people need more than one medication to get their blood pressure under control.
Especially if their hypertension is severe.
Exactly. And if they have other health conditions to consider.
Right, so it's like creating a team of medications, each with its own strengths.
That's a great way to put it. By using drugs from different classes, doctors can target multiple mechanisms at once.
Makes sense. So what are some examples of these combination products?
Well, one common one is an ACE inhibitor with a thiazide diuretic, like lisinopril hydrochlorothiazide.
Okay.
There are also ARBs combined with thiazide diuretics, like losartan hydrochlorothiazide.
Makes sense.
And sometimes you might even see 3 meds combined, like amlodipine valsartan hydrochlorothiazide.
Wow, it seems like there's a combination for just about every need.
There really is. And that's where the expertise of a doctor really comes in, helping to navigate those choices and find the best fit for each individual. But what happens when even multiple medications aren't enough to bring blood pressure under control?
That's a bit concerning. What happens then? Are there any other options?
There are, but it does lead us into the territory of resistant hypertension, which can be a bit more challenging to manage.
Resistant hypertension. That sounds serious. What exactly does that mean?
It's when blood pressure stays high, even after trying at least 3 different types of blood pressure meds, including a diuretic.
So it's like blood pressure that just refuses to cooperate. But why would someone develop resistant hypertension? Is it just like extra strong high blood pressure, or is there something else going on?
It's rarely that simple, unfortunately. There are a few different reasons why someone might have resistant hypertension. Sometimes it's as simple as medication adherence.
You mean people not taking their meds as prescribed?
Exactly. People skip doses because of side effects, or sometimes they think they don't need them anymore.
That makes sense. Consistency is key with any chronic condition.
Absolutely. And sometimes lifestyle factors can play a role too. If someone's still eating a lot of salt or drinking a lot of alcohol, it can make it harder to control their blood pressure, even with medication.
So it's like fighting an uphill battle.
That's a great way to put it. And then there are underlying medical conditions that can contribute to resistant hypertension. Things like sleep apnea, kidney problems, or hormonal imbalances.
It's like a whole web of interconnected factors.
Exactly. So how do we unravel that web and treat resistant hypertension? It starts with a thorough investigation. Doctors need to rule out any underlying medical conditions, address those lifestyle factors, and make sure the patient is actually taking their medications correctly.
It sounds like detective work.
It is. And then it might involve adjusting medications, trying different combinations, or even exploring newer treatment options. It's a real team effort between the doctor and patient.
Speaking of newer treatments, I remember Dr. Hasan mentioning pharmacogenetics. He seemed pretty excited about it.
Pharmacogenetics, that's the study of how your genes affect your response to drugs.
So, like how your genes determine if a medication will work for you or not.
Exactly. And not just if it works, but also the likelihood of side effects.
Okay, I see. So give me an example.
Sure. Certain gene variations can affect how quickly your body breaks down beta blockers.
So someone with a certain gene might need a higher dose to get the same effect.
Exactly. Or a lower dose to avoid side effects.
Wow, that's amazing.
It is. And sometimes a medication might not work at all for someone because of their genes. Dr. Hasan gave a few examples. He talked about how variations in certain genes involved in drug metabolism can affect the breakdown of hydrolysine.
Hydrolysine, that's a vasodilator, right?
You got it. And he also mentioned how slight variations in DNA, called polymorphisms, can influence the metabolism of methyldopa, another blood pressure medication.
Wow, so our genes really can have a big impact on how we respond to medications.
They really can. That's why pharmacogenetics is so exciting. It has the potential to help doctors personalize treatment plans based on each person's genetic profile.
That's incredible. It's like creating a custom-made treatment plan just for you.
Exactly. But of course, there are ethical considerations too.
Right. If doctors start routinely testing for these genetic variations, what happens to that information? Who has access to it?
Those are all important questions, and they're being actively discussed in the medical community. We need to make sure that genetic information is used responsibly and that people's privacy is protected.
I'm glad to hear that. Okay, ready for another challenge? Dr. Hasan included another multiple-choice question.
Let's do it.
Okay, here we go. A patient has a genetic variation that prevents them from quickly metabolizing drugs by acetylation. Acetylation is just a process the body uses to break down certain drugs. You'd be most concerned about this variation if the patient was taking which drug? Sotalol, clonidine, nitroglycerin, hydrolysine, or prazosin.
Okay, so we need to figure out which drug's metabolism is most likely to be affected by this genetic variation.
Right.
Let's see. I think the answer is hydrolysine. Remember, Dr. Hasan specifically mentioned that hydrolysine metabolism is influenced by variations in those acetylation genes.
That's right. This genetic variation could mean that hydrolysine builds up in the body, increasing the risk of side effects.
Exactly. This is a perfect example of how pharmacogenetics can help doctors choose the right medications and dosages.
Though less trial and error, more personalized treatment.
Exactly. Now, before we wrap up, Dr. Hasan included one more case study. Ready for it?
Absolutely. I love a good case study.
All right, so we have a 59-year-old man being treated for high cholesterol, diabetes, and hypertension. He goes to the doctor for a follow-up 3 weeks after starting a new medication.
Okay.
He's feeling fine, no complaints, but his blood work shows high potassium and a jump in his creatinine.
Creatinine, that's a sign of kidney problems, right?
Yep. So the question is, which of his medications is most likely responsible for these changes? He's currently taking lisinopril, metoprolol, atorvastatin, hydrochlorothiazide, furosemide, metformin, and prazosin.
Okay, so we need to figure out which medication could cause both high potassium and kidney problems.
You're getting it. This case really shows how important it is to think about all the potential effects of a medication, especially when someone is taking multiple drugs.
Right, because drug interactions can be tricky.
They can. So what do you think?
I'm going to say lisinopril, the ACE inhibitor.
You got it. ACE inhibitors can sometimes cause those side effects, especially if someone already has some kidney issues.
So even with personalized medicine, monitoring is still super important.
Absolutely. It's all about catching those potential problems early. Now let's circle back to combination therapy for a moment. We've talked about how using multiple medications can be a really effective strategy. Dr. Hasan included a whole list of common combination products in his notes. Which one stands out to you as the most interesting and why?
Okay, let me think. They all seem pretty strategic, like each combination is targeting different aspects of blood pressure control. But one that caught my eye is aliskiren hydrochlorothiazide. It's also known as Tecturna HCT.
Oh, interesting choice. Why that one?
Well, remember aliskiren, that unique renin inhibitor, it basically shuts down the renin-angiotensin-aldosterone system right at the beginning.
Right, like cutting off the problem at the source.
Exactly.
Yep.
So combining that with hydrochlorothiazide, a thiazide diuretic that helps reduce fluid volume, seems like a powerful combination.
I see your point. It's a two-pronged approach, tackling two different mechanisms at once.
It really shows how important it is to understand how these medications work, both individually and in combination.
You got it. Now, ready for a rapid-fire challenge? Let's see if you can match these brand names to their generic components.
Oh boy, rapid fire. Hit me with it.
Okay, here we go. Diuretic, Atacand HCT, Azor, Capacide, Adarbichlor, Exforge, Lotensin HCT, Lotrol, Monopril HCT, Pristalia, Prinazide, Diuretic, Tarca, Tevetin HCT, Twinsta, Unuretic, Vasoretic. Ready?
All right, deep breaths. Okay, Diuretic is quinapryl hydrochlorothiazide. Atacand HCT is candesartan hydrochlorothiazide. Azor is amlodipinol misartan. Capazide is captopryltanachlorothiazide. Adarbichlor is azyl sartanchlorthalidone. Exforge is valsartan-amlodipine. Lotensin HCT is benazepryl hydrochlorothiazide. Lotril and amlodipine and benazepryl. Monopril HCT is fosinopril chlorothiazide. Prestalia is perindopril amlodipine. Prinazide and Diuretic are both lisinopril hydrochlorothiazide. Tarca is trandilopril verapamil. Tevitin HCT is eprosartan hydrochlorothiazide. And Vasoretic is moxicpril hydrochlorothiazide. Vasoretic is enalapril hydrochlorothiazide.
Wow, you're on fire. Keep going.
We've got aldactazide, avalate, Benicar HCT, Corzide, Diavon HCT, Dutapol, X4J HCT, Hyzar, Indiride, Wilpressor HCT, Micardis HCT, Cacturna HCT, Teneritic, Trivensor, and Ziac.
Okay, let's see. Aldactazide is spironolactone hydrochlorothiazide. Avalide is irbesartan hydrochlorothiazide. Benicar HCT is olmesartan hydrochlorothiazide. Corzide is natolobendroflumethiazide. Diavon HCT is valsartan hydrochlorothiazide. Dutaprol is metoprol succinate hydrochlorothiazide. Exforge HCT is amlodipinolvalsartan hydrochlorothiazide. Hyzar is losartan hydrochlorothiazide. Indiride is propanol hydrochlorothiazide. Lopressor HCT is metoprolol tartrate hydrochlorothiazide. Tocoartis HCT is tomasartan hydrochlorothiazide. Tecturna HCT is aliskiren hydrochlorothiazide. Teneritic is atenolol chlorthalidone. Tribenzor is olmesartan-amlodipine hydrochlorothiazide. And last but not least, Ziac is bisoprolol hydrochlorothiazide.
That was amazing. You got them all. You've really learned a lot about how these medications work and how they can be combined to effectively manage hypertension. It's been a great learning experience, but I know this is just the tip of the iceberg. There's always more to learn, and new research is coming out all the time.
Exactly. That's why it's so important to stay informed and have open conversations with your doctor about your individual needs and concerns.
Well said.
Mm-hmm.
So what are your thoughts on the future of hypertension treatment? Where do you see things heading?
I think we're going to see even more personalized approaches to treatment, taking into account not just a person's medical history and lifestyle, but also their genetic profile.
So more emphasis on pharmacogenetics.
Absolutely. And who knows, maybe one day we'll even be able to use gene editing to actually correct the underlying genetic variations that contribute to hypertension.
Wow, that would be revolutionary. But even with all these advancements, it's important to remember that lifestyle modifications are still the foundation of good blood pressure management.
You're absolutely right. Those lifestyle changes we talked about earlier, weight management, diet, exercise, stress reduction, those are crucial for everyone, regardless of whether they're taking medication or not.
It's like taking a holistic approach to your health.
Exactly. It's about addressing all the factors that contribute to high blood pressure, not just relying on medications to fix the problem.
So it's a team effort, doctors, patients, and those healthy lifestyle choices all working together.
That's a great way to put it. And one thing Dr. Hasan emphasized was the importance of empowering patients to take control of their health.
Absolutely. Knowledge is power, and understanding how these medications work, along with making those healthy lifestyle changes, can really make a difference.
It really can. And don't be afraid to ask your doctor questions. The more you know about your condition and your treatment options, the better equipped you'll be to manage your health effectively.
Well said. So before we move on to the next part of our deep dive, let's just take a moment to recap what we've learned so far. We've covered a lot of ground today.
We have. We started by talking about the basics of hypertension, the different categories, and why it's so important to catch it early. Then we dove into the two main types of hypertension, essential and secondary, and all those sneaky risk factors that can contribute to high blood pressure.
We even explored how some everyday medications, like those over-the-counter decongestants, can raise blood pressure. That was an eye-opener for me.
It's easy to forget that even those seemingly harmless over-the-counter meds can have unintended consequences. And then we delved into the fascinating world of the body's blood pressure regulation systems, those intricate feedback loops that work tirelessly to keep everything in balance.
Those baroreflexes and the renin-angiotensin-aldosterone system, they're like the unsung heroes of our circulatory system.
They really are. And speaking of heroes, we then moved on to the stars of the show, those antihypertensive medications. We started with diuretics, the classic fluid flushers, and then explored the heart-calming beta blockers.
We even tackled those tongue-twisting ACE inhibitors and ARBs, uncovering their unique mechanisms and those pesky side effects, like the infamous ACE inhibitor cough.
Right, and don't forget about aliskiren, the renin inhibitor that cuts off that blood pressure-raising cascade right at the source.
It's like shutting down the factory before it can even produce those troublesome hormones.
Exactly. And then we explored the world of calcium channel blockers, those tiny gatekeepers that regulate calcium flow into muscle cells.
We even talked about how calcium channel blockers are often the preferred choice for Black patients because of those differences in renin activity.
That was a great example of how personalized medicine is becoming increasingly important. And speaking of personalization, we even delved into the fascinating field of pharmacogenetics, where our genes hold the key to tailoring treatment plans for maximum effectiveness and minimal side effects.
It's like having a custom-made roadmap for managing your health.
Exactly. And we tackled a few real-life case studies along the way, putting our knowledge to the test and learning how doctors make those crucial treatment decisions.
It was like solving medical mysteries.
It was, and I think we both emerged as blood pressure detectives extraordinaire.
I'll take that title. But before we get too carried away with our detective work, I think it's time to move on to the next chapter of our deep dive. Dr. Hasan still has a few more categories of anti-hypertensive medications to cover, and I'm eager to learn more about those lesser-known players.
All right, let's do it. We've got centrally acting adrenergic drugs, alpha blockers, and vasodilators waiting in the wings, each with their unique mechanisms and applications.
Sounds intriguing. Let's dive in and uncover their secrets.
So, ready to explore those other categories of antihypertensive meds, those centrally acting adrenergic drugs, alpha blockers, and vasodilators.
Let's do it. I'm always up for learning about the lesser-known players.
They each have their own, quirks and uses.
All right, let's start with centrally acting adrenergic drugs. What makes them special?
Well, they work directly in the brain.
In the brain. Okay, that's different.
Yeah, they target the sympathetic nervous system.
Right, the fight-or-flight system.
Exactly. And when you're stressed, that system goes into overdrive.
Heart racing, blood vessels constricting.
Yep, all that fun stuff. So centrally acting adrenergic drugs, they basically calm that system down.
So they're like chill pills for your brain?
Pretty much. They interfered with those signals that tell your blood vessels to constrict.
Which leads to?
Vasodilation. Those blood vessels relax, widen, and blood pressure goes down.
Ah, I see. So which drugs are we talking about here?
The main two are clonidine and methyldopa.
Clonidine and methyldopa. Okay, what's the difference?
Clonidine directly stimulates those alpha-2 receptors in the brain.
Those are the ones that act like brakes on the sympathetic nervous system, right?
Right. And methyldopa, it's actually converted into something else in the brain, which then acts on those receptors.
So different pathways, same outcome.
Exactly. And interestingly, methyldopa is often used for hypertension during pregnancy.
Pregnancy. Why is that?
Well, it's been studied extensively, and it's considered safe for both the mother and the baby.
That's good to know. All right, side effects. Anything we should be aware of?
Sedation is a common one with both clonidine and methyldopa. You might feel drowsy or tired, especially at first.
Not surprising since they're working in the brain.
Right. Clonidine can also cause constipation. And importantly, you can't stop taking clonidine suddenly.
What happens if you do?
You could get rebound hypertension, a dangerous spike in blood pressure.
So, taper off slowly with your doctor's guidance.
Always a good idea. Okay, ready to move on to alpha blockers.
You get me.
Alpha blockers, they target those alpha-1 receptors.
Which are involved in?
Vasoconstriction. Remember, that's the tightening of blood vessels, which raises blood pressure.
Right, right.
So alpha blockers block those receptors, preventing vasoconstriction.
So the blood vessels can relax and widen?
Exactly. Leading to, you guessed it, lower blood pressure.
All right, I'm following. What are some common alpha blockers?
Prazosin, doxazosin, and terazosin are a few examples.
Okay, I'll jot those down. But I think Dr. Hasan mentioned that they're not usually the first choice for treating hypertension anymore.
Yeah, that's right. The side effects can be a bit much, especially when you're first starting out.
Side effects. What are we talking about?
Well, one common one is reflex tachycardia. That's when your heart rate speeds up to compensate for a sudden drop in blood pressure.
Right, the body's trying to maintain balance.
Exactly. But with alpha blockers, it can overcompensate, leading to a rapid heartbeat.
Okay, so that's not ideal. Anything else?
Another common side effect is postural hypotension. That's the lightheadedness you feel when you stand up too quickly.
Oh, I get that all the time.
Right. Well, alpha blockers can make that worse, which can be a problem, especially for older people who might be at risk of falling.
Makes sense. So it sounds like alpha blockers are kind of the backup plan, not the first line of defense.
That's a good way to put it. They're used when other medications haven't worked or in situations where their specific properties are beneficial. Oh, and Dr. Hasan mentioned a special type of alpha blocker called labetalol.
Labetalol, wasn't that a dual-action medication?
Yes, it's both an alpha blocker and a beta blocker.
Double the blocking power.
Exactly. It blocks both alpha-1 receptors and beta receptors, which makes it useful for things like gestational hypertension and hypertensive emergencies.
Okay, so it's a bit more specialized.
Right. All right, ready for the last category? Vasodilators.
Vasodilators. Those sound pretty straightforward.
They are. They relax the muscles in your blood vessels, causing them to widen.
So more blood flow, lower pressure.
Exactly. The two main ones are hydralazine and minoxidil.
Hydralazine and minoxidil. Got it. What else should we know about them?
They can lower blood pressure quickly, but they can also cause that reflex tachycardia we talked about.
A rapid heartbeat.
Right. And they can increase renin levels, which can lead to fluid retention.
So it's a delicate balance.
It is. Vasodilators are often used in combination with other medications, especially for severe or resistant hypertension.
And hydralazine is used for high blood pressure during pregnancy.
Yep. So they definitely have their place. What about side effects? Anything notable? Hydralazine can cause headaches, tachycardia, nausea, sweating, even chest pain in people with heart disease.
Okay, that's a lot.
It is. And minoxidil has a rather interesting side effect. Hypertrichosis.
Hyper what? What in the world is that?
It just means excessive hair growth.
Wait, so minoxidil can make your hair grow faster?
It can. It can actually cause hair to grow in your face and body.
That's crazy. So it's a blood pressure medication and a hair growth treatment in one.
Yep, it actually is. It's used topically for male pattern baldness.
That's wild. Okay, one last challenge before we wrap things up. I think Dr. Hasan had one more multiple choice question about vasodilators.
Bring it on.
Okay, imagine a patient is rushed to the ER with a crazy fast heartbeat after overdosing on a medication. His family says he's been really down about his hypertension lately. Which drug could cause this kind of dose-dependent increase in heart rate? Captopril, hydrochlorothiazide, Loratadine, minoxidil, or verapamil?
Okay, this one requires us to put everything together.
Right. Think about those mechanisms and side effects.
All right, let me see. I'm going to go with minoxidil. It's a potent vasodilator, and a big overdose could definitely cause that extreme tachycardia.
That's right. You nailed it. We covered so much ground today. Diuretics, beta blockers, ACE inhibitors, ARBs, allosterine, calcium channel blockers, centrally acting adrenergic drugs, alpha blockers, and vasodilators.
Wow, we did. It's amazing how much there is to know about managing hypertension, isn't it?
It really is. And this deep dive was just a starting point. There's always more to learn, and new research is constantly emerging. But hopefully, this episode has equipped our listeners with a solid foundation of knowledge about those essential antihypertensive agents.
Absolutely. And remember, knowledge is power, especially when it comes to your health. Talk to your doctor, ask questions, and be an active participant in your healthcare journey.
Couldn't have said it better myself. So thank you for joining us on this deep dive into the world of antihypertensive agents. We hope you found it informative and maybe even a little bit fun. And until next time, stay curious and stay well.
Bye, everyone.